I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome our very renowned doctor, Dr. Manoj Kumar Goel. Sir is MBBS, MD, FCCP, DIP, FIAB, FISDA, FICM, FISM, Principal Director and Unit Head at Fortis Memorial Research Institute, Gurgaon, Delhi. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is COPD or asthma, cracking the code of overlapping airway disease. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, sir.
Thank you, Sion, for the nice introduction and introduction of the topic. It's my first appearance on this platform, and I'm very pleased to be there. So we are going to talk about something which is very pertinent, and every physician and every, whether he is in a tertiary care hospital or somebody who's doing general practice, everybody, finds these cases in their clinical practice. And this is something which is a very common problem in the country. So let me share my slides and then we can move ahead. So I hope my slides are visible now.
Yes, sir, it is visible. Just make it a full screen, sir.
All right. So here we go. So what we are going to talk about is asthma and COPD. Both are the obstructive airway disease and quite common in the country. In fact, India is the world capital of asthma and COPD. And problem is that majority of the patients are not diagnosed early. And even though patients are diagnosed, the treatment is not appropriate. And many of these patients land up with severe problems, with chronic respiratory disability and, lot of other comorbid conditions which make their life quite miserable. So what I generally find in practices, and the people come to me from general practice especially ask, it's very difficult to differentiate between asthma and COPD, and they think that asthma and COPD are the same and they require similar kind of treatment. But the fact of matter is that we have to manage them differently, and that is what we are going to talk about. So just to introduce a little bit, bronchial asthma and COPD are obstructive pulmonary disease that affect millions of people all over the world. And with the largest burden of asthma and COPD patients, and not only the largest burden, the most severe form of COPD and asthma burden is in our country. Now, these two lists have many similarities and many differences. Similarities in terms of their symptomatology, but differences in the pattern in which these two conditions present. But because there are similarities, it causes confusion amongst the therapists in diagnostic and management of these diseases. Both asthma and COPD have different etiology, different symptoms in terms of severity, especially. So symptoms may be the same. They may present with cough, dyspnea, sputum production, and these may be the common symptoms. But their presentation is different. Their behavior is different. They've got different types of airway inflammation. We know that both asthma and COPD are inflammatory conditions, but they've got different, pathophysiology, different inflammatory cells, different mediators, and different consequences of inflammation. And they have a different response to therapy. So the therapy that we use for asthma may not be appropriate for COPD, and similarly, therapy that we use for COPD may not be appropriate for asthma. So it's very important that we diagnose them appropriately, and they have a different course. Right? If they're not treated appropriately, they got a different course and different outcome. So coming to definition, asthma is a chronic inflammatory disorder of the airways, which is airway hyperresponsiveness. This is the key word, airway hyperresponsive. What it means, the airways become more responsive, more reactive to the surrounding atmosphere, where they produce, hyperreactive response in terms of inflammation. And these patients present with recurrent episodes of wheezing, breathlessness, chest tightness, and coughing. Important thing is recurrent episodes. They are not permanent episodes, they're recurrent. So it's an episodic disease, right? So usually it is associated with variable airflow obstruction, and that is often reversible either spontaneously or with the treatment. So it's an episodic disease. The patient would become symptomatic, You treat them and it becomes normal. All right. And sometimes, even without treatment, the patient recovers. And similarly, they have got a variable airflow obstruction. So you may find the FE1 dropping down to 50%, and after 2 months of treatment, you find the FE1 coming back to more than 80%. So this kind of behavior is there in asthmatic patients. Whereas sorry, whereas COPD is a disease which is characterized by persistent respiratory symptom. As I said, asthma has got episodic symptom. Here, these symptoms are persistent, and their patients will complain of persistent dyspnea, cough, and respiratory production. The airflow limitation stems from the airway or the alveolar destruction. So COPD is a destructive lung disease where there is destruction of the small airways. It's typically caused by substantial exposure to noxious particles or gases, for example, tobacco, smoke, biomass fuel, air pollution, workplace hazards. So actually, COPD is a man-made disease where asthma could be inherited, but COPD is a man-made disease because of the various atmospheric exposure, especially tobacco and smoke, which lead to the development of COPD. Now, unlike asthma, which is often diagnosed early in life, COPD is a progressive condition of declining lung function that typically appears in diagnosed after 40 years of age. So, childhood start with symptoms of asthma, with recurrent coughs, wheezing, and sputum. But COPD generally, it presents after the age of 40 years. Coming to pathogenesis, both asthma and COPD are associated with inflammation of the respiratory tract, but with a different pattern. This is what I'm going to talk about. So there are factors which influence asthma, which include host factors, environmental factors. Those factors would include atopy, so they may have other atopic features like allergic rhinitis or maybe allergic conjunctivitis or maybe urticaria. The key factor is the airway hyperresponsiveness, which I already explained. And sometimes obesity also is a host factor for asthma. And unless you take care of the patient may persist with symptoms of asthma, with persistent symptom of asthma. Therefore, sometimes it is called as obesity-induced asthma. Then you got certain environmental factors which act as a trigger over the host factors, like allergens, which may be indoor, which may be in the form of the domestic mice or animals like dogs, cats, and mice, cockroaches, mole, yeast, and there could be outdoor allergens like pollens. Infections, mostly viral, occupational, if there is atmospheric exposure in dusty conditions, tobacco smoke, and indoor air pollution. These are the triggers, right, which can precipitate an attack of asthma or flare the asthma condition in the patient. Risk factor for COPD, the commonest risk factor and the most important risk factor is cigarette smoking, right? So somebody who is smoking regularly is at higher risk of developing COPD. And air pollution resulting from the burning of wood and other biomass fuels has also been identified as COPD risk factors, especially in our household, where in the rural areas where biofuel is quite often used in the form of chula and other things. That produces a lot of smoke, and that's a very important cause of COPD amongst the women in villages. Now, coming to airflow limitation, both the conditions are characterized by airflow limitation. And in asthma, the inflammation affects all airways, but its physiological effects are most pronounced in the medium-sized airways. So asthma is basically the medium-sized airways. With COPD, the chronic airflow limitation is caused by a mixture of small airways, right, where there is an obstructive bronchiolitis and parenchymal destruction, where the patient will present with emphysema. So those who got inflammation in these small airways, right, they will present mainly with something called bronchitis-like picture. Whereas when there is destruction of the alveoli and the terminal airways, they present with emphysema, right, where you find a lot of bullae. These changes diminish the ability of the airway to remain open during the expiration. Basically, what happens is the inspiration is easier, but when we tend to exhale, these terminal airways collapse, as a result of which, there is air trapping, and that causes, further respiratory distress and dyspnea in these patients of COPD. Coming to inflammatory cells in asthma, the mast cells plays a very important role. It is activated by allergens through IgE receptors. The mast cells release various bronchoconstrictor mediators like histamines, the leukotrienes, and prostaglandins. These are potent bronchoconstrictors. The eosinophil is another very important inflammatory cell. In fact, 50% of the patients that we get in India have got eosinophilic phenotype. And these eosinophils, when activated, release basic proteins that may damage the epithelial cells and have a role in airway remodeling. So patients with eosinophilic asthma would have, permanent damage to the airways, which we call as airway remodeling, which limits their reversibility. Then T lymphocytes in the airways release specific cytokines which include IL-4, IL-5, 9, IL-13 that orchestrate eosinophilic inflammation and IgE production by B lymphocytes. Similarly, but in COPD, the main inflammatory cells are neutrophils and macrophages. Right, the neutrophils are important in mucus hypersecretion through release of proteases, and macrophages produce increased inflammatory mediators and proteases that may show defective phagocytosis. T lymphocytes and B lymphocytes also play an important role in the pathogenesis of COPD. Both CD4 and CD8 cells counts are increased in the airway wall and lung parenchyma with a big CD8 CD4 ratio, which is important because CD8 cells are cytotoxic to alveolar cells that lead to the alveolar cell destruction, right? Destruction of the alveoli, and that leads to the development of emphysema. Right. See, the parenchyma keeps the terminal airways open because of its elasticity. So once the lung parenchyma is destroyed, the alveoli and alveolar cells are destroyed. That elasticity is lost and the terminal airways become collapsed. So that is what happens in COPD and especially in emphysema, where you got a lot of bullae and destroyed lungs and airflow obstruction. The B cells are also increased in peripheral airways and within lymphoid follicles, possibly a result of colonization and infection. Eosinophils also play an important role in COPD pathogenesis, and in some patients, eosinophil is an important trigger. And these are the patients of COPD who respond to inhaled corticosteroid, where ICS is indicated in the management of COPD. Coming to the diagnosis, so these are the features of asthma and COPD in one slide. The asthma, the onset is usually before the age of 20 years. There is variation symptoms over minutes, hours, so the patient may be fine in the morning and maybe symptomatic with dyspnea in the afternoon, then by evening he may become all right. It has been observed that symptoms are worse during the night or early morning. So the patients would generally present with nocturnal cough. So somebody who is coming to you with persistent nocturnal cough, you must suspect asthma. Symptoms are triggered by various triggers like exercise, emotion, or dust, allergen, exposure, as I talked about the environmental environmental factors. These patients would have variable airflow limitation, the FEO would vary. Lung function remain normal between the symptom in those patients who don't have the advanced disease, but if the disease become advanced, so some element of chronic obstructive lung disease appears, and these patients then start behaving like COPD patient. But generally, the lung functions become normal during the symptoms. Family history of asthma and other allergic conditions would be there. Symptoms do not worsen over time. Symptoms vary seasonally. So you would always find a lot of seasonal variation in these patients. And these patients respond well to bronchodilator therapy, show a good and early response, quicker response, and better responses compared to COPD patients. And when you do a chest X-ray or CT scan, these patients, majority of the time, the X-ray would be normal or the CT scan would be also normal, except in those who go to advanced asthma patient, asthma with advanced disease, who then behave like COPD. The COPD patient, you find the patients come to you after the age of 40 years. They would have persistent symptoms despite treatment. So even though you give them bronchodilator therapy, they would be suffering from the symptoms. They may have a good and bad days, but always daily symptom exertional dyspnea would be theirs, right? So they can have exacerbation and flares, during which time their symptoms would deteriorate, but otherwise, even their good days, they would be symptomatic, especially they would be having exertional dyspnea. The history of chronic cough and sputum, which precedes dyspnea, unrelated to the triggers. So triggers are very important in asthma, like your pollution, your change in weather, right? But in COPD patient, you don't find any history of triggers. The persistent airflow limitation, lung function remain abnormal between the symptoms, between the flares. There is history of heavy exposure to tobacco smoke or biomass fuel, which is the most important factor in the pathogenesis of COPD. Symptoms slowly worsen over a period of time, especially if the patient continues to smoke. So if the patient continues to smoke, whatever bronchodilator therapy you give, the patient will have a loss in their lung function and they would deteriorate symptomatically. They get limited relief by bronchodilators, where the patients of asthma get a quick and almost complete relief with the bronchodilator therapy. But because of the fixed obstruction, COPD patients have a limited relief. And you will find severe hyperinflation of the lungs as because of air trapping, as I just told you, due to the air trapping during the expiratory phase. So you find the diaphragms are down and the lungs are inflated. And you may find many times bullous lung disease also. So, what are the clinical indicators for considering diagnosis of COPD? The patient with COPD will have a dyspnea that is progressive over a period of time, worse with exercise and persistent. These patients may have recurrent wheezing. They would have a chronic cough, which may be intermittent, maybe non-productive, but the cough would persist, something called the smoker's cough, which is there, about which the patient himself may not be aware, but the family members would say that he keeps coughing. There is history of recurrent lower respiratory tract infection in these patients, and you have to evaluate for the risk factors. As I said, tobacco smoke is the most important. Then smoke from the home cooking, as in our ladies from the villages. Then occupational exposure and host factors like sometimes general factors like alpha-1 antitrypsin deficiencies and premature children, childhood respiratory infections, or patients who have got a childhood asthma. These are the history of these are the risk factors for development of COPD. Now, spirometry is extremely important, where this is the normal spirometry, but in case of COPD, what happens is the FE1 reduces and both FVC also reduces. So both are reduced, and most importantly, the ratio between FE and FVC is less than 80%. So that is what happens in the spirometry with the airflow obstruction. Now, when you do a spirometry, you also do a post-bronchodilator reversibility, where you ask the patient to inhale the salbutamol or a combination of salbutamol and ipratropium, and you look for the reversibility of the spirometry. So this blue line is the before reversibility, that is the nave test, and the red curve is of the spirometry after the bronchodilator therapy. And you can see in asthmatic patients, this is the pre-test 2.76 liter, that is 63.3%. As you can see, the FE1 is reduced. Normal FE1 is more than 80%. And after giving the bronchodilator, you see the FE1 improves to 72%. There is an improvement by 13.6%. So if the FE1 improves by more than 12% or by more than 200 ml, right? So as in this case, from 2.76 to 3.13. So there is almost an improvement of 400 ml, right? So there's improvement in FE1 more than 200 ml and percentage by 13%. Then we say it's a good reversibility, and that is suggestive of bronchial asthma. And as you can see, the FE1 FVC ratio is 71%. Normally it is more than 80%. So as you can see in this patient, the FE1 percentage is reduced. This is the pre-test, is 63.3. The FE1 FVC ratio is reduced 68% against 70%. But the important thing is there is a reversibility of 13.6% after giving a bronchodilator. So this is suggestive of asthma. Whereas in COPD patient, you find that the FE1 is reduced less than 60%. This is a pre-test 60%, post-test 59.5%. This is a post-bronchodilator, and you can see there is no reversibility. And FE1 SC ratio is less than 80%, that is 55% in this patient. So this curve where you find there is no reversibility after the bronchodilator response, right, then it is suggestive of COPD. So spirometry can help you differentiating between COPD and asthma. Now coming to the management part, the goals of treatment of both the disease is to reduce the symptoms, which is very important. To reduce the number of exacerbation, because remember, each exacerbation triggers another exacerbation and causes further worsening of the respiratory condition and the lung function of these patients. And thirdly is to improve the quality of life, because majority of the time these patients, especially it's a severe disease, it's a very disease with disability with persistent symptoms. They're not able to sleep, they're not able to do their day-to-day core activities. So quality of life is a very important goal in the treatment. So first I'll talk about the management of asthma. For management of asthma, you need two types of therapy: controller therapy, lever therapy. The controller medication are used to reduce the airway inflammation, because that is our target. So if you can reduce the inflammation, the bronchial hyperactivity is reduced, the bronchospasm is reduced, right? So that is the very key. To reduce the airway inflammation, therefore, inhaled corticosteroid remain the cornerstone in the management of asthma. To control the symptoms, reduce risks such as exacerbation and related decline in lung functions. But if you control inflammation, all 2, 3, 4 are taken care of, right? That's why inhaled corticosteroid remain the treatment of choice. And that's why you have to give inhaled corticosteroid regularly to these patients. And that's why these are called as prophylactic therapy or the controller medication. Because if you control inflammation by control medication, the asthma comes under control, remains under control. Okay. And therefore, this therapy may be required to be given for a long period of time in these patients. What are the controller medications? Inhaled corticosteroid called ICS alone and in combination of long-acting beta agonists are the first-line controller medications taken regularly once or twice a day as maintenance therapy. Important thing is the patient has to take this ICS or ICS-LABA combination even when he doesn't have any symptoms to prevent recurrence of asthma or to prevent the occurrence of asthma flare. That's why they're called controller medicine or also called as maintenance therapy, where the patient has to use regularly, irrespective of the fact that he's got a symptom or not. He has to continue his regular the controller medication, ICS or ICS-LABA combination, to prevent the occurrence of asthma flares and control the symptoms. As such, anti-inflammatory agents like corticosteroids remain the first line and cornerstone treatment of asthma. This is what I have been telling you repeatedly. So there are other controller options, right, which are generally used as add-on therapy. So if the response to ICS-LABA combination is suboptimal, or despite patient on appropriate ICS-LABA therapy is experiencing frequent the symptoms and exacerbation, then you may have to add other control options, which may be LTRA, that is what you call as Montelukast, that you have LAMA, that is long-acting muscarinic like tiotropium. Then sublingual immunotherapy may be advised in some patients who have got a allergic diathesis, especially with house dust mite. Then azithromycin is used in low dose, 250 milligram once daily as a controller medication as add-on therapy to ICS-LABA. And sometimes when LTRA and LAMA combination is not enough to control the symptom, then you add azithromycin. And then you got a severe asthmatic patients who are in step 5 of GINA guidelines, then you may need these special medications, biologicals, which is not within the domain of discussion today. But these are available where even the most severe case of asthma can be treated effectively. Coming to reliever medication, as the name suggests, are for the emergency. When the patient has got asthma flare, has got a worsening of symptoms, then you give this reliever medication to give a quick response to the patient. Okay. So reliever medications are the quick relief medications. These are used to relieve acute attack of bronchoconstriction, which are primarily bronchodilators like beta-2 adrenoceptor agonists like SABA, and formoterol, which is LABA, but is used as a rescue medication. And I'll talk about formoterol. Then short-acting muscarinic agent like ipratropium, and xanthine preparation like theophylline. So the worldwide theophylline is now not used in the management of asthma and COPD, but Indian guidelines do recommend the use of theophylline as a reliever medication in difficult cases. But the core reliever medication remains SABA or a combination of SABA-SAMA combination, that we call is a ipratropium solbutol combination. It is available as a duolin. So these are the short-acting beta-2 adrenoceptor agonist SABA. As you can see, the albuterol, salbutamol, levosalbutamol, prevalent. I'm sure all of you are aware of these. The important thing, they have got a rapid onset of action and short duration. So because they rapid onset of action, they give quick relief. Okay. So this is the advantage of SABA as a quick relief medication, and they're available as MDIs, DPI, the nebulized solution, and they are quite commonly used as rescue therapy. Then you got a long-acting beta-2 receptors LABA, which are primarily used as a controller therapy, which include formoterol, salmeterol, and now you've got ultra LABA combination, ultra LABA, where the duration is increased to now 24 hours. They last for 24 hours. So inducterol, ulaterol, now vilanterol, they are available where the duration of actually is more than 24 hours. So they are called ultra LABA. But formoterol, salmeterol are called LABA, where the duration of action is 12 hours. The important thing with formoterol is, as I said, is that it has a very rapid onset of action. It's less than 5 minutes, which is as good as salbutamol, levosalbutamol. It's got a long duration of action. So now formoterol is also used as a rescue therapy. Okay, so that is very important. Rest all are not used as rescue therapy. The only long-acting beta agonist which is used as rescue therapy or reliever therapy is the formoterol. Then this concept called anti-inflammatory liver therapy, AER, because scientists believe that is inflammation is the key. So even when the patient has increased symptoms, so just bronchodilators are not good enough. So it's better to add some inhaled corticosteroid these patients. So anti-inflammatory liver drugs are the liver inhaler that contains both rapidly acting inhaled corticosteroids and rapidly acting bronchodilators. So it takes care of the symptomatic relief and also reduces the inflammation, which has an additive effect, and that gives not only controls the inflammation better and improves the symptoms much faster. And as I said, formoterol is the only LABA which is used as a reliever therapy in combination with ICS also. So there are two types of anti-inflammatory liver drug that we have: formoterol with low dose inhaled corticosteroid, which may be budesonide and beclomethasone, and then you got an ICS salbutamol combination, right? So these are the two combinations which are available. So I'll discuss both of these. And the non-formoterol LABAs like salmeterol, indocatrol, they are not used as anti-inflammatory reliever combination. So we have a inhaled corticosteroid formoterol combination which can be used as a reliever, the controller therapy, and this drug also has the advantage of being used as a reliever therapy, right? So the single inhaler can be used both for maintenance and also for relief. So that's why the concept has come as a single inhaler therapy, where the same inhaler, same combination of isoformoterol used as a maintenance, as a control therapy, and it can also be used as a reliever therapy. So this is the latest concept, and that is the most recognized concept. So we are using a combination of isoformoterol most of the time in our patients. So MART therapy, also called maintenance and reliever therapy, can be used only with the combination of isoformoterol inhalers such as budesonide formoterol and beclomethasone formoterol. These are the two combinations which are used as the AIR, or the maintenance and reliever therapy. Okay, budesonide formoterol, beclomethasone formoterol, where you can give this combination as a maintenance therapy to control symptom and also as a reliever. Combination of ICS with non-formoterol LABAs or ICS SABA cannot be used as MART. So remember, ICS and short-acting beta, like from the budesonide and the salbutamol cannot be used as MART because this is a short-acting reliever only. It doesn't have a maintenance therapy. For maintenance therapy, you need a long-acting beta agonist like formoterol. That's why even ICS LABA can not be used as a maintenance and reliever therapy, can only be used as a reliever therapy. MART is also sometimes called a SMART therapy, that is single inhaler maintenance and reliever therapy. The meaning is the same here. So means the patient has got only one single inhaler that he keeps it in his pocket, use it morning, evening as a controller. And as and when he has got a symptom, he can use it on SOS basis. So it's very useful, especially for children. So you can keep this inhaler, of combination of budesonide formoterol in their bag. So if the child any time in the school feels, experiences any flare of that asthma symptoms, he can use it immediately, and he's not confused which inhaler to use, blue inhaler, red inhaler. He's not confused. So these are the GINA guidelines. Now we got the two tracks of GINA. The track 1 and track 2. The track 1 is the MART therapy that I have already described. The track 2 is where the other any ICS or any LABA is used. So most of the time it is the MART strategy which is used. So I'll be discussing that, and we as a chest physician promote this strategy also, which is simple to use and very easy to follow, right? So in MART therapy, use the ICS formoterol as a maintenance therapy, and also for reliever use, ICS formoterol as maintenance. So single inhaler therapy is used for track 1. So this is how it is used. So these are GINA guidelines, the various steps. The step 1 and 2, where the patient has symptom less than 4 to 5 days a week, is not very symptomatic. So in those cases, the patient can use the combination of ICS formoterol, that is budesonide and formoterol, on SOS basis. The most commonly available is, I'm not promoting any formulation here, but the most commonly used the formoterol for example. So you can use formoterol on SOS, the Foracort inhaler on SOS basis. Step 3, when the patients experience symptoms most days or working with asthma once a week or more. So if the patient is symptomatic for most days, then you can use low dose maintenance ICS formoterol therapy morning, evening, right, on regular basis. So step 1 and 2, it's only SOS whenever the symptom there, but from step 3 onwards, it becomes a regular medication. In step 4, the patients experience daily symptoms, wakes up asthma once a week or more, and patient has got a low lung function. So if you do the spirometry, the functions are low, then it falls into the category step 4, where you step up the dose of ICS formoterol to the medium dose, and then it's used as maintenance therapy. And step 5 is when the patient has got daily symptoms and is still symptomatic and requiring high dose of maintenance ICS formoterol therapy. Then in those cases, you may add LAMA, and then these patients may be referred for biophenotyping and biological therapy, as I talked about. Okay. Now, in all these steps, you can use inhaled corticosteroid formoterol and SOS basis for symptomatic relief. Now, coming to the management of COPD, smoking cessation is the only disease-modifying approach. So if the patient continues to smoke, then whatever treatment you give, the patient would be symptomatic and would have further deterioration in lung functions. Now, unlike asthma, bronchodilators are the cornerstone in the management of treatment of COPD, which improve airflow and reduce hyperinflammation. Right. So unlike asthma, where the IC is the cornerstone, the bronchodilators are the cornerstone in the management of COPD patient. In contrast to asthma, benefit of anti-inflammatory ICS are restricted to patients with frequent exacerbations and some patients with elevated eosinophil levels. So use ICS only in patients who are frequent exacerbators and those who got a high elevated eosinophil counts. So this is the gold AB assessment tool. So you confirm the diagnosis of COPD by doing a spirometry in a patient who's got a persistent cough, breathlessness, and sputum production. If you do the spirometry, find the FE and FE's ratio is zero point 0.7, then you diagnose it as COPD. Then based on the lung functions, you assess the airflow obstruction divided into 4 grades like this. So grade 4 is when the FE is less than 30, and grade gold 1 grade is when the FE is more than 80. And then you assess the symptom and risk of exacerbation by dividing into 3 groups. Group A is when the patient experiences the less exacerbation, that is 0 1 exacerbation a year, and he's not very symptomatic, that is MRC 0 to 1 and CAT score less than 10. Group B is when the patient is not frequent exacerbator but is symptomatic most of the time. And group E is a patient who has got a frequent exacerbation of at least 2 exacerbation a year, or at least 1 exacerbation requiring hospitalization. Right, so these are 3 groups A, B, and E. So broadly speaking, A are the patient not exacerbating but less symptomatic. Group B are not exacerbating but significantly symptomatic, and group E are the patient who are experiencing frequent exacerbation. So in group A, what you do, you give a bronchodilator, which may be a LABA or LAMA. Generally, is the LAMA which is preferred. In group B, where the patient is more symptomatic, you give a combination of LABA and LAMA. That is called a dual bronchodilator therapy. And in patients in group B who are frequent exacerbation, you give a higher dose of LABA and LAMA. And if the patient has got frequent exacerbation and has got blood eosinophil count more than 3, then you add ICS to inhale count. So you give a triple drug combination in case of LABA, in case of group E. Okay, when they are frequent exacerbation and the eosinophil count is more than 300. So you got 2 kinds of patients in the follow-up who would be more dyspneic and the patients who would be experiencing more exacerbation. So for dyspneic patient, you give either start with LABA or LAMA. If the patient still continues to be having dyspnea, then you add LABA and LAMA, right? And you also have to watch for their initial devices. Maybe if this combination is not working, then you switch to another LABA LAMA combination. Or maybe you can switch to from DPI to MDI or MDI to DPI or with nebulization. Now, those who are exacerbating, you start with LABA or LAMA. If the blood eosinophil count is less than 300, you give a combination of LABA or LAMA. If the blood eosinophil count is more than 300, you immediately start with a triple drug combination of LABA, LAMA, and ICS. Now, if the patient becomes better, then what you do, you de-escalate to inhaled corticosteroids and just maintain them with LABA or LAMA. On the other hand, if the patient on LABA, LAMA continues to experience exacerbation, if his blood eosinophil count is more than 100, then give them a triple drug combination. If the blood eosinophil count is less than 100, then again you can give roflumilast, which is not very popularly used, commonly used, but azithromycin could be a preferential, particularly patients who have been former smokers. Okay, so this is a plan for escalation and de-escalation for patients who are frequently exacerbating. The important thing is somebody may ask why we don't want to give too much of ICS in patients of COPD, because there is a high risk of pneumonia in these patients. That's why you want to avoid ICS unless it is really required. So this would be this slide shows the indication of initiating inhaled corticosteroid in COPD patients. So ICS would be recommended. This history of hospitalization for exacerbation COPD, more than 2 moderate exacerbations COPD per year, if the blood eosinophil count is more than 300, and history of or concomitant asthma, what you call the COPD asthma syndrome or overlap. Favor use if there is one moderate exacerbation COPD per year and a blood eosinophil count is between 100 to 300. But do not use inhaled corticosteroid if there is a repeated pneumonia, even this patient is having mycobacterial infection, that is tuberculosis, and blood eosinophil count is less than 100. So these are the contraindications. There would be strong indication, and between two is the relative indication. So just to summarize, asthma is a chronic inflammatory disorder of the airways characterized by recurrent episodes of wheezing, breathlessness, chest tightness, and coughing. Remember, it's a recurrent episode. Asthma is associated with the variable airflow obstruction that is often reversible, either spontaneously or with the treatment. So we call asthma as a reversible lung condition, lung disease. Whereas COPD is a disease characterized by persistent respiratory symptoms, which may at times are progressive despite treatment. Unlike asthma, which is often diagnosed early in life, COPD is progressive condition of declining lung function that typically appears and is diagnosed after the age of 40 years. The goal of treatment is to reduce symptom, number of exacerbation, improve quality of life both in asthma and COPD. ICS alone and combination of ICS LAVA are the first line controller medications taken regularly once or twice a day as medicine. So if you are dealing with a patient or treating a patient, inhaled corticosteroid has to be there in their treatment, irrespective of the fact whether they're diabetics or what, they have to be used. Track 1 or smart therapy is the preferred therapy. In asthma, we use a single inhaler of formoterol and ICS combination, both for maintenance reliever, for relief symptoms. In COPD, bronchodilators is a cornerstone of the management. You want to avoid ICS because of high risk of the pneumonia. Triple therapy with ICS, LAMA is used in COPD patients who are frequent exacerbated and high eosinophil counts. Control of triggers in asthma and smoking cessation COPD are the important intervention in the outcome of these patients. So that's very important. So asthma, you look for the triggers, find out the trigger, whether he's using a perfume or there are some pets there in the house, some mold is there, right? Smoke, agarbatti, dhua, all those things have to be avoided. They have to be told to the patient. Similarly, all patients with COPD should be put to a smoking cessation plan, which is again a very important intervention. Thank you very much for your patient hearing. And I just stop sharing my slides.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up.
Right.
Yeah. So, sir, the first question is, how can overdiagnosis of asthma in smokers and underdiagnosis of COPD in the elderly avoided?
So smoke, of course, smoker is the main most important factor for COPD, but smoke is very important trigger for asthma as well. So that is why this smoking history is important. The presentation of the symptom is different. Whereas in COPD, the symptoms would be persistent, right? There's no bad. There could be bad days and good days, but they would be having symptoms. Whereas in asthmatic patient, they would have, recurrent symptoms. Between the symptoms, they would be fine. And you can do a spirometry in these patients where if you find the reversible airflow obstruction, it is asthma. If there is not reversible, it is COPD. Elderly patients, again, you have to have the symptoms, you have to do a spirometry, and then you can diagnose whether this patient got asthma or COPD. But if the patient who is not a smoker, the possibility of COPD is less until there are other triggers which are there, like household, biogas quicking. Those could be the factors.
Next up, sir, in resource limited settings, how can primary care physician accurately manage ACO without advanced diagnostic?
So you don't need very advanced tests for these patients. The spirometry is a very simple test. The machine doesn't cost much. It's available in almost all the cities, and the test generally costs rupees 500 or not more than that. So symptomatically, you can assess them. You have to take a good history. You have to look for any triggers. You have to take the history of smoking. So if you have to evaluate the patient clinically, majority of the time you are able to diagnose them on clinical basis itself. But spirometry does help. So I think clinical assessment and basic spirometry is at least the bare minimum that is required for the diagnosis of these patients. And that doesn't cost much, as a matter of fact.
So there's one last question. How does pathopsychology of ACO differs from classic asthma?
The pathophysiology means the asthma is the disease of airways, which affects all the whole full length of the airway, including the large, small, and the medium size. Whereas the asthma, there is no destruction as a fact. The lung parenchyma is not destroyed. It is the airway inflammation that is there. Whereas in COPD, there is the airway is obstructed because of the destruction of the lung parenchyma, which loses elastic tone to keep the airway open, right? So this is the main difference, and that's why the asthmatic patient, you find that this inflammation may be reversible, so if they become symptom free and they have got a complete normal airways. Whereas in COPD patient, the airways do not become normal at any point of time. So that is the main difference between the two, and therefore you fear COPD more. But if asthmatic patients are not treated properly and they're experiencing frequent exacerbation and they're not taking inhaled corticosteroids as a cornerstone treatment, Then over a period of time, these patients also going to develop irreversible airflow obstruction, and then they start behaving like COPD patients. So early intervention, early diagnosis, and taking care of the trigger is the most important in the proper management of both these diseases of airflow obstruction.
Understood, sir. Thank you so much, sir, for answering all our questions. That's all from our audience, sir. Before concluding, sir, any take-home message from your end?
I think the asthma and COPD can be easily diagnosed, and they should not be misdiagnosed. That's very important. You need just very little bit of effort to diagnose them, as a matter of fact, and you have to spend little time with them. And there are many fears amongst the patients about the use of inhalers. You have to tell them inhaler is the first line and best line treatment. So first you have to get yourself convinced that inhaler is the best line of first line treatment. So this is what you have to explain to the patient. That needs time, spending time, especially in the first meeting. You have to tell them how to use their inhaler devices properly and check it frequently whenever they come back to your OPD. There are a lot of apprehension about use of inhaled corticosteroids, especially if the children, the parents are quite averse to it. So you have to explain to them the benefits of ICS and tell them that it's very safe. These are good steroids, and they are the standard of treatment. Otherwise, they may develop chronic respiratory disability, which not. So I mean, it needs a little bit of counseling. So I know the GP, the time is very much limited with the practitioners, but then in first meeting, at least you spend at least 5-10 minutes with them and explain the various questions, so that these patients become your part of management. If the patient disappear, they don't become part of your team, and the family doesn't become part of the team, then the problem is there. And that's why India remains the world capital of bad asthma and bad COPD, and we have to get rid of it.
Thank you so much, sir, for joining us today. And it's a pleasure to have you here. Thank you, sir. With your
Thank
permission, I
you.
would like to conclude today's session.
Thank
Thank you.
you. Same here. Thank you.